Good afternoon, good evening, everybody. My name is Patrick van Reenen. I am the host of this webinar, and I will do this webinar together with Richard Russell and with Marianne Samin, both from the UK. Before I start, I would like to thank the Hepatology Committee of ESPGHAN for organizing this webinar. This webinar is a culmination of a 2-year collaborative effort of HepCom and the IBD Porto Group. Representatives from both groups have worked together on a position paper, which will be published online in January 2025. In the coming 45 minutes, we will give you a sneak preview of the paper. Since presenting guidelines can sometimes be a bit dull, we have opted to include some interactivity. During this webinar, several questions will be asked and you can respond via Slido. You can register for the quiz by logging into slido.com and entering the following code, 1194299. It is quicker if you scan the QR code. And I will give you 30 seconds to make these preparations right now. So scan the QR code with your smartphone, enter your name, and then you are ready to go. The code will be shown again during this webinar, so if you are a bit late, then no worries, you can log in at a later stage as well. So after this webinar, you will be equipped with evidence-based knowledge on the diagnosis, monitoring, and treatment strategies for children with PSC-IBD, enabling you to apply best practices. I will start by providing you with some information about the methodology behind the position paper, and following that, Professor Richard Russell, pediatric gastroenterologist at the Royal Hospital for Children and Young People in Edinburgh, will take over to discuss the gastroenterologist's perspective, and we will conclude with a contribution from Marianne Samin, pediatric hepatologist at King's College Hospital in London, who will then discuss the hepatologist's perspective. Hepatologists and gastroenterologists each bring their own perspective to manage patients with PSC-IBD. In the position paper, we aimed to integrate both viewpoints. This picture was created by ChatGPT. It turned out quite appropriate. However, I do have some doubts about the instrument the gastroenterologist is holding. The first step in our project was to formulate clinical questions deemed relevant for the care of children with PSC-IBD. The core group formulated 7 clinical questions. The first 3, shown here, were structured using the PICO format for diagnostic tests, where P stands for population, I for index test, C for comparator, and O for outcome. We searched for evidence in the medical literature regarding the predictive value of elevated liver enzymes for PSC or autoimmune hepatitis. Additionally, we investigated which follow-up examinations are most appropriate for children with IBD and elevated gamma-GT levels. Finally, we reviewed literature on calprotectin testing in patients with PSC who do not have known IBD at the time of their PSC diagnosis. One prognostic PICO was formulated, or rather a PO, where E stands for exposure. We investigated the time to dysplasia or colorectal carcinoma in patients with PSC-IBD. Finally, we formulated 3 therapeutic PICOs, where I stands for intervention and C for comparator. We searched the medical literature for the effects of UDCA and oral vancomycin on liver-related complications, as well as the effects of corticosteroids and anti-metabolites in patients with PSC and autoimmune hepatitis features. Evidence from the literature was assimilated and core messages were developed. The quality of evidence was classified into 4 categories following the GRADE approach shown in block 1. The core messages were then shared with the sounding board of international experts and subjected to a vote, shown in block 2. Statements that achieved at least 80% agreement were considered final, while others were refined and submitted to a second online vote or rejected. The selected statements were ultimately classified as either strong or weak. Weak recommendations indicate significant variation in the decisions of the voters, meaning that physicians need to engage in a shared decision-making process with patients. Strong recommendations suggest that almost all voters would choose that intervention or index test. Let us take a look at the perspective of the pediatric gastroenterologist. Of every 100 children diagnosed with IBD, 43 will experience at least one episode of elevated liver enzymes. Among these 43, 8 will eventually develop an autoimmune liver disease, including PSC. Now let us look at it from the perspective of the hepatologist. Of all patients diagnosed with PSC, approximately 80% have concurrent IBD. This percentage is possibly an underestimation resulting from a relatively short follow-up or a lack of proactive investigation for IBD. In children with PSC-IBD, the diagnosis of PSC and IBD is usually at the same time. In a minority of cases, the PSC component becomes visible during follow-up, or conversely, the IBD component becomes visible during follow-up. We have now arrived at the first interactive moment. You will soon be asked to use your smartphone to answer the following question. Which of the 3 images best represents the distribution of gut inflammation in PSC-IBD? So grab your smartphone and join the Slido quiz. And I see, very good, I see many people coming in now. I really like that. I just wait till we see more. We have over 30 participants now in the quiz. People are still coming in. Before we started, we heard that there were approximately 200 people that subscribed to this webinar, but I don't know if everybody is there. I suggest that I continue with the question once we have reached 60. Now 55. Now it stops. Okay, I move on now to the question. So again, which figure shows the typical distribution of gut inflammation? Is that A, the image of pancolitis, B, the patchy distribution in small and large intestine, or C, severe inflammation in the proximal colon and decreasing towards the rectum? You can now make your choice. Out of 66 who entered the quiz, now 57 have answered. Very good. So I see that 48 chose pancolitis, 43% answer C, and 9% chose B. And the correct answer, it should be appearing now, but somehow this is not. Yes, there it is. So the correct answer was C. Most children with PSC and IBD have colitis with a predilection for more severe inflammation in the right colon, as opposed to ulcerative colitis, which is characterized by uniform inflammation of the colon and rectum, or increasing severity of inflammation towards the rectum. PSC patients whose IBD is labeled Crohn's disease usually have colonic involvement. Isolated ileitis or extensive small bowel involvement is very rare in PSC-IBD. Before I hand it over to Richard Russell, I would like to check if there are any pressing questions right now. Marianne, did you have a look on the questions that have been posed so far?
There isn't any question so far.
Very good. Okay, so then I hand over to Richard.
Excellent, thank you very much. Hi everyone. Patrick, can I control the screen?
No, I will click forward for you.
Ah, right, okay, that's great. So thank you very much for everybody for joining. I would just like to take the opportunity to say thank you to Patrick as well. He's done a very good job to bring the IBDologists and the hepatologists together on this very important topic, and it wasn't always easy to get us to do things in a timely way, but he very politely encouraged us, and I hope when you read the document next month you find it a useful basis for us starting to work collaboratively together. So let's talk through a case or two just to, I suppose, bring the position paper into real life. So this is a typical case, so a 12-year-old, 2-month history of occasional bloody diarrhea 3 times a day, bit of weight loss, difficult pain which is interfering with schooling and activities outside of school, and is just behind his peers in terms of growth. So this would be a barn door patient that we would see in our IBD clinic. So you can see the investigations there, so just to chat you through them. So they're anemic, raised platelets, raised inflammatory markers, and an ALT of 85 with a low albumin, and stool work showing negative stool culture and a calprotectin of 655. So what are you going to do if this is the patient that you see in clinic tomorrow? Which of these approaches are you going to take? So are you going to do nothing, knowing that liver tests can be raised at IBD diagnosis? Are you going to look for PSC and related other liver pathologies? Are you going to go for an ultrasound or an MRCP? Are you picking up the phone or emailing your friendly hepatologist? Or are you going to investigate them duly at the time of their endoscopy? This guy has IBD for sure, doesn't he? So are you going to arrange a liver biopsy at the time of endoscopy? So I think you should be able to make choices now. Patrick, you'll need to keep me right in terms of how many people are voting.
I will do so. It's now 20 out of 68.
Ah, right. Maybe mine was a harder question than yours. Every answer is good. Remember, this could be the patient sitting in front of you in clinic tomorrow.
We have reached 50 out of 70 now.
Okay, well, just click on when you think the moment is appropriate.
Yeah. There are still new people entering the quiz. We have reached 60 out of 73.
Yeah,
I click to the next one.
Yeah, okay. All right, okay, so you're investigators rather than waiters. So, and I suppose from first principles, this is a webinar about PSC, so it might not be too surprising if you chose extended liver tests. But actually, I would say the answer most commonly employed in my clinical practice would be number one. So actually, the point of this is really to say, what is the threshold that we choose abnormal liver tests at, and when is the right time to wait and see if they resolve, and when is the right time to do more extensive examinations, be they blood tests or imaging. So clearly, most people didn't go for anything beyond further blood work, and it's not wrong to do that, but I think you may, in your clinical practice, see lots of patients who have mild derangement of their LFTs at IBD diagnosis that then subsequently resolve and don't need investigated. Can I get the next slide? So to try and help you get some context to this, we've got just some words from the position paper. So we said in children with suspected or confirmed IBD, which this patient is, coexistent liver disease is higher in patients with elevated liver enzymes, very obvious. What we didn't do in this case deliberately was to do both tests. So one of the things that you need to know for this guy is what is his gamma GT as well as his ALT. So one of the learning points is to do both, and some hospitals will do them both automatically if you ask for liver function tests, and some hospitals won't, and you have to ask for them independently. So it's important in the context of IBD that you're getting both of those blood test results. And the part that we really haven't covered yet, and is the point of this case, is significant or persistent elevation of liver enzymes prompts further diagnostic workup. So what is significant? So how high is significant? So that's obviously higher than all of the reference ranges that we would use within our hospitals, although there is some inter-hospital variation to a degree. And it's obviously not persistent because these are the first time that we've done these liver tests. So just to move on to the next slide, then in patients who have normal liver screening tests, then we're recommending that they're done at 3 to 6 monthly intervals, and then that extended testing is done when liver enzymes are twice the upper limit of normal, and that upper limit of normal will vary between different hospitals. So in my hospital, that would be about 1.5 above the upper limit of normal, and you're thinking about, I'm being a bit pedantic there, but actually we see this situation very commonly at IBD diagnosis, and a lot of the time, if it's minor, you give them treatment and it will resolve, or you just wait and it will resolve. So I guess there's a balance between not ignoring raised liver function tests and not performing extended investigations too much. So good to discuss that maybe at the end to see if anybody disagrees with that point of view, which would be also a very valid thing to do. Next slide. So we've talked about that, but what I would certainly do next in practice for my repeat liver function test would be to add a gamma GT, and then at your repeat liver function tests, then it's a question of, do you wait to see if they're high and store the blood, or do you take the extended function test anyway because you're rebleeding the patient? So there will be individual patient circumstances which both approaches would be valid. You can obviously wait on your repeat test before you thinking about arranging what would usually be an ultrasound to start with. Next slide, please. So this boy was diagnosed with Crohn's disease. Nobody's getting a prize for that, and there's not a slide on that. He was given exclusive enteral nutrition and his liver tests were repeated 4 weeks later, so ALT and gamma GT both normalised. He had extensive small bowel disease on his MRI, and so he went on to combination therapy with infliximab and azathioprine commenced during his exclusive enteral nutrition. Then he comes back to your outpatient clinic 6 months later, and he has the following liver test. So a raised ALT, this time higher than previously, having normalised in between, just to be clear. His gamma GT is 30, his albumin 40, and other standard blood tests, including inflammatory markers in blood and stool, are all normal. So what are you thinking about the most likely cause of the liver test abnormalities here? So has he developed PSC? Patrick already showed you earlier that it is possible. It's commonest to have them both together at diagnosis. Is this drug-induced liver injury? Is this coincidental and he has an intercurrent infection? Or is this a Crohn's disease flare and his LFTs are increasing a little bit like they did at diagnosis? So now is your time to vote.
Voting starts now. %50 has voted now. $60 out of 75 voted.
I think that's our threshold. I think we may have some observers or people with no smartphones or smartphones that don't work. So the commonest answer here is drug-induced liver injury, and that is a very good answer. So talking through the other answers, so could it be PSC? Well, the patient had a normal gamma GT, although they had a significantly raised transaminases, so less likely. Intercurrent infection, if that was the case, then possible, but less likely. So the other bloods there were normal, and similarly with a Crohn's disease flare, less than 1% of patients with a flare will have a normal calprotectin and normal blood inflammatory values. So drug-induced liver injury, over half of you came to the correct diagnosis there, so well done. So this indeed is the commonest cause of significantly raised liver enzymes in children with IBD, so you should always think about it. And most of the drugs that we use and treatments that we use, including antibiotics, can potentially cause it, although some are more likely than others. In cases like this, then you need to go back to first principles and look at the time where you started a particular therapy, and then look to see when the liver test changed, and then you may then decide to stop the therapy and re-challenge, or if it's significant, just decide to use a different therapy. In this case, obviously, we started 2 therapies at the same time, and both infliximab and azathioprine would have the potential to cause liver test abnormalities. So you may have to decide to stop one because the child has significant Crohn's disease, and then reassess your liver function tests. And if they normalise, then you may have answered your question, and if they don't, then come back to it. But next slide. So it should have said drug. Okay, we can go to the next one. Here are just some further blood tests to help us try and distinguish between the 2 potential therapies which have both started between normal liver function tests and then them being abnormal at follow-up. So the infliximab should say trough, not through concentration, is 10.5. So for those of you not familiar, very standard level, 6TG 275. So again, that's within the normal therapeutic range. But then you have a 6 mmP, so your thiopurine metabolite, which is very high. So again, this is a situation where some patients will be shunters, so they will preferentially go to the inactive metabolite of thiopurine, and a proportion of these patients, they will then show elevated transaminases. So a lot of people will be shunters and they have normal LFTs, but in some it will go up. So your next option here, what I would personally practice, is to split your dose of azathioprine into two, so give half in the morning and half in the evening. But with Patrick and others, we wrote also in the last Crohn's disease guideline, you can significantly reduce your dose and then use allopurinol. So you're going to use around 25 to 50% of your total dose, and watch out very carefully for any signs of myelosuppression when you're on allopurinol. Splitting the dose is very safe, and you don't have to worry about those other things. For both of those, then obviously you just need to look at your liver function tests after a suitable period of time, and if they normalise, you're done, and if they don't normalise, then you need to do your liver workup, because they may have developed liver disease at follow-up. So I think I'm ready to take any questions. I'm very happy for you to actively disagree with any of the parts of the case, or answer any other questions that you might have. I haven't been able to, I know some things came up in the chat as I was talking, but I wasn't able to do both things at once, so I didn't see any relevant questions which might have come up there.
I think, Richard, there's just one comment, but it's more about, I think, Patrick's presentation, that despite colitis with the rectal sparing is the most common described phenotype in literature, we always see pancolitis in the real world. So that's a comment that was made. So
I think that is a useful comment, and I think one of the issues we have with PSC-IBD is we have a lack of good prospective cohorts from within Europe, and within our own individual practice we might see different disease phenotypes. But I think one of the things that we hope will come out of this work is for us to work together to understand the full range of patients with PSC-IBD that are seen in clinical practice, not limited to an IBD centre and not limited to a hepatology centre, so we can understand and agree or disagree with observations like yours, who you always see a pancolitis in a much broader group of patients. So that's a very helpful perspective. And as a follow-up to this next year, we would hope to come back to the much wider ESPGHAN group through the IBD interest group and through the hepatology group to try and collectively work together to get a big cohort of patients to understand this.
Okay, Marianne, I think you can continue with the presentation.
Yeah, I think there's one other question, but maybe we'll, there's one about ALT and gamma GT. If ALT and gamma GT are more than twice normal at presentation, would you do liver biopsy with endoscopy before giving steroids? That's the first question.
Okay, so we might have different perspectives on this. So I would certainly do an extended liver workup to understand what the autoantibodies and things were, and we would certainly do some imaging. I think it is a point for discussion whether you would do a liver biopsy at that point or you would wait, and some of that might depend on your treatment strategy for your IBD. So if you're going to give, for example, exclusive enteral nutrition, then you're rushing to the liver biopsy is perhaps less than with steroids. But you certainly want to do an extended liver workup and some imaging. Whether you would take that as far as a biopsy, I think you would be doing an MRCP first and then taking stock of your results before you would move onto a biopsy, would be my own take on it.
There's another question more about medication. Why allopurinol and ASA reduction and not stop ASA and go with infliximab monotherapy?
That would be another choice. That would be another choice. So particularly as the patient's calprotectin has normalised, that would be, I think, an equally valid strategy. I guess I was trying to look at clinical scenarios where we were talking about, alteration based on drug alteration rather than stopping. But stopping the therapy would be an equally valid thing to do in this case as well. You would need the clinical context of the patient, obviously.
And then there's two more, and then I think we're probably better move on. But so at time of diagnosis of PSC, in what time we should start to screen for IBD?
Do you not answer that question in your...
Yeah, probably.
Yeah.
I'll say the other one is more for you. What do we do in a patient with PSC without abdominal complaints, normal stools, normal fecal calprotectin, and normal ultrasounds of the abdomen? Always colonoscopy, ?
So I think if you have a completely normal calprotectin and no IBD symptoms, then it's difficult to persuade the patient to have a colonoscopy. Personally, I think because the co-occurrence is so high, I probably would do it anyway, but I think I'm going to leave it to Marianne's talk. I think these two questions have set your talk up nicely.
Yeah. Patrick, maybe you want to comment from your point of view?
Yeah, there are different views. There is no consensus about the cutoff for calprotectin. Some say that once you have diagnosed PSC, just scope the patient to be sure that there is no low active inflammation. Others say, no, just don't waste your resources on that, but only scope when the calprotectin is above 150. So different views. Marianne, are you going
to? Yeah. So this is a friendly hepatologist that you've been calling or is seeing some patients as well. So other way around, to a hepatologist, you see a patient or you've been kind of referred a patient who was diagnosed with ulcerative colitis age 13, is now 17. And there's these ongoing symptoms of lethargy and more recently developed some itching, which is associated rash on the ankles. Patient also has a positive serology for celiac disease and has been starting on a gluten-free diet. Upon questioning, she has missed some of her periods, which previously were regular, and there is kind of progression of the symptoms. So looking at the blood test, you can read the results kind of notice that the white cell count is low, platelet count is low, mildly elevated bilirubin levels, very high alkaline phosphatase, elevated transaminases, and preserved synthetic function with a normal albumin, and the clotting was also normal. So the ultrasound scan in this patient showed intrahepatic bile duct dilatation and evidence of hepatosplenomegaly. So in this scenario, and again, one of the position statements is that MRCP is the modality of imaging modality of choice to explore evidence of sclerosing cholangitis. And so this is a picture that you see in a patient who has kind of quite advanced disease. You shouldn't really be seeing the bile ducts very clearly if you've got a normally draining biliary system. But when you kind of get narrowing and strictures and dilatation, you get this picture. And the other thing to look out for, or your radiologist will look out for, kind of any evidence of more dominant strictures. With regards to the ultrasound scan, some of the ultrasonographers are actually able to kind of look at the thickening of the common bile duct. And again, that can be useful to be picked up if they are looking for it. So it's a bit strange wording of the question, but which of the following options should not be considered at this stage? So we'll let you get on with answering the question.
There are 78 participants, and they can start voting now. 3 options: IgG and autoantibodies. The second option is trial treatment with UDCA. And the third option is liver biopsy. Which of the following should not be considered at this stage? A third of the participants has voted now. Two-thirds have voted now. We have reached 55 out of 79, and it stops. I suggest that we move to the next slide.
It's interesting. So from our point of view, we would actually recommend further exploration first in this patient. There are some signs that the patient has a bit more advanced liver disease with hepatosplenomegaly. There is also, kind of aside from the ulcerative colitis, celiac disease as well. So in our practice, we would explore further with initially with doing an extended screen, as Patrick was Richard was referring to, it kind of course excluding any virology, but immunoglobulins and autoantibodies would definitely be the first thing we would do in these patients. Oh, so what we wouldn't do? Yeah, sorry, I'm just getting confused. You're right. So half of the people say not to use ursodeoxycholic acid as a trial treatment. That's right. So there is a lot of controversy, or actually kind of a disagreement about doing liver biopsy, and particularly if you also look at the adult literature and adult recommendations, where if anything, gamma GT is also not included in the baseline blood tests that are done for a diagnosis of PSC. And as you know, PSC is more typically a disease that we see in adolescents. So some of these patients actually directly present to adult services, so might kind of follow a bit of a different trajectory than when they are seen in pediatrics. So after a lot of discussion, this is what we came up with regards to what's the role of liver biopsy and when to consider it. And so the first indication was having a normal biliary tree at MRCP. So you get this cholestatic picture, symptoms, for example, of itching, but the patient doesn't have any significant biliary dilatation or cholangiopathy on the MRCP. And then you would like to do a liver biopsy to kind of exclude small duct disease, which particularly in the adult literature has been more associated with Crohn's disease than with ulcerative colitis. And again, in the adult experience, had kind of a better prognostic outcome. If there are raised immunoglobulins and presence of liver-specific autoantibodies, that's another indication to do a liver biopsy. And then we also agreed that if there is clinical uncertainty prior to starting steroid induction therapy. So in these patients, that would be kind of different because they've already been diagnosed with their inflammatory bowel disease. But if that kind of coincides, the picture that you see, then that might be helpful as well. but you can see there's low certainty, and there is kind of, but the agreement was there. Next slide. So just a bit more about immunoglobulins and autoantibodies. Immunoglobulins can be elevated in IBD as well, or not that specific. And I think the message with regards to the autoantibody screens is which autoantibodies do you look for, and how do you look for them? So we know that the ELISA method is not particularly reliable. So it is important that you actually do the proper immunofluorescence on a freshly prepared rodent tissue. And the other thing of note is actually making sure that your lab kind of considered low titers. So we know in pediatrics in general, in autoimmune hepatitis and autoimmune liver disease, that the titer threshold titers for positivity that are applied in adults are not really reliable in children. So we kind of would say positive autoantibodies are anti-LKM1 in 1 in 10, and anti-nuclear and anti-smooth muscle antibody 1 in 20. Typically, what we see is the majority of patients with sclerosing cholangitis, autoimmune sclerosing cholangitis, tend to have the positive anti-nuclear antibody and smooth muscle antibody, and it's less commonly seen in the other autoantibodies. ANCA is an antibody which is very kind of common in IBD, so that on its own wouldn't really kind of make you say or kind of comment that this patient has an autoimmune sclerosing cholangitis or sclerosing cholangitis autoimmune overlap. There's about 3 terminologies that are kind of going around to describe this condition. So if you decide to do a liver biopsy, and again, it is kind of depending on your practice and your experience, what Richard was referring to before, we did a study looking together with our colleagues in Cambridge, where when patients were presenting with colitis at the time of their colonoscopy, a liver biopsy was done, but that's not really the routine and the standard practice. But just to tell you what you see on the typical histological findings of sclerosing cholangitis, PSC, and then with the autoimmune overlap. So on slide A, what you see is this typical kind of periductal fibrosis. So in the bile ducts are kind of surrounded by thickened endothelium, and there is also often some ductular reaction. So you can see some smaller bile ducts around the bigger bile ducts. There can be some inflammation around the ducts, and sometimes you can actually see if the cholestasis is very severe, you can actually see some bile plugs or bile that is stuck in the bile ducts. If you kind of compare A and B, you can see that this second picture is much kind of more has got dark purple features, and this is what we see in the autoimmune picture, where there is this concept of interface hepatitis, so inflammatory inflammation spilling out of the portal tracts into the parenchyma in a kind of interface way, and the type of cells you see that kind of color much kind of dark purple are the plasma cells and also the lymphocytes. And then I think you can agree that the last picture actually shows a combination where you have these kind of onion skin changes around the bile ducts, which we kind of how we commonly describe it, but also kind of there is inflammation there. And particularly if you see plasma cells, then you would kind of think that this is a more inflammatory type of sclerosing cholangitis. So with regards to kind of therapy and what do you do with those results is, again, if you see at the bottom of the statement, there's low certainty. And I think that was a common theme when we went through the literature, that there is very limited kind of data currently, or reliable data or studies, apart from the large study done by Marc Deneau. But again, there was no consensus necessarily there about doing biopsies and kind of including histology in that kind of context. But the agreement of the people who reviewed the statements was kind of, they agreed, 95% agreed. So we came up with this statement that in children who have a combination of PSC and IBD, and they have biochemical, serological, and histological features of autoimmune hepatitis, the use of corticosteroids and antimetabolites may suppress immune-mediated hepatitis. And as you notice, it's all kind of very carefully worded in may suppress. I think the general experiences in PSC is that despite some of the patients treating the inflammatory component, some of these patients do still progress and get a more kind of biliary picture that is kind of left with no inflammation. And there is kind of a line of thinking as well, whether there is just a progressive, this is a progressive phenotype from a more inflammatory that we more typically see, because when compared with adult experience, we more commonly diagnose autoimmune sclerosing cholangitis compared to what the adults see. However, in the absence of convincing autoimmune hepatitis features, the use of corticosteroids and antimetabolites is not indicated to manage PSC. So you see this patient, so the patient had a biopsy, it was more in keeping with PSC. So the patient was not started on immune suppression. Having said that, the patient wants to know, and the parents want to know, what is going to happen in the future, which is a common question and concern from our patients, particularly again when they look at the PSC support kind of documentation and leaflets, which is kind of is very probably not always applicable to the young people and the children. So again, the question is phrased a bit inversely, which is a complication that this patient is unlikely to develop over time. We're talking about kind of next 5 to 10 years.
81 persons in the quiz, and they can start voting now. Option 1 is bacterial cholangitis. Number 2, cholangiocarcinoma. Number 3, variceal bleeding. Number 4, synthetic failure with coagulopathy and ascites, and intractable pruritus. It should be an S in the end. Which is the complication that this patient is unlikely to develop in the coming 5 to 10 years? 50% has voted now. Just wait a bit till more have completed this question. I don't see any new answers coming in. Oh, there is. Let's move to the next slide.
Yes. So I think it's kind of divided. From the experience, again, in pediatrics, cholangiocarcinoma is very rare. So unless the patient has a dominant stricture and there are kind of some concerns of MRCP, the patient might proceed to having an ERCP, but cholangiocarcinoma is rare, what we see in children and young people. Whereas the other complications, the intractable pruritus and the bacterial cholangitis are complications we do see, particularly in the patients who have a diffuse cholangiopathy, as was the case in this patient. And again, synthetic failure and coagulopathy, with coagulopathy and ascites and variceal bleeding, in this context of this patient already having low white cell count and low platelet count, in keeping with the degree of portal hypertension. So these would be both biliary and portal hypertensive complications we would expect much more likely than cholangiocarcinoma. Yeah.
Okay, this is the end of the interactive part. And we see that CJ has reached the first place. Congratulations. And you will get a free copy of the position paper once it is published in January. That is for everybody because it's an open access paper.
So referral criteria for liver transplantation, which we also included in the position paper. And again, the suggestion kind of made before really are things you get worried about these patients, and we actually would recommend early referral to a liver transplant center for assessment rather than waiting. In this case, the patient I discussed, within a few months, they kind of actually became very jaundiced, had recurrent cholangitis, and then developed kind of synthetic failure. And they had to be listed for transplantation. Luckily, they didn't have to wait too long and have recovered well. Interestingly, the colitis did become more active again about 6 months after liver transplantation. One other comment I just wanted to make is for the hepatologist looking after patients with autoimmune hepatitis, again, is to keep an open mind that the phenotype might change over time. And it's now not uncommon for some of our patients to, once they've been transitioned to adults, a few years later, to actually really having started from an autoimmune hepatitis picture on histology, treated with kind of immune suppression, to kind of progress to a more biliary picture. And again, particularly if there is association with IBD and other kind of conditions like celiac disease. So even in patients who have initially been labeled as autoimmune hepatitis, our recommendation would be to continue to monitor with ultrasound scan, and if there is any changes there, to kind of proceed to MRCP.
Thank you, Marianne. We have reached the end of the webinar. It is close to 6:30. That is Central European time. I would like to thank all the experts who have participated in the writing of this position paper. As already announced, it will be published next month. It will be online then. And before we close this webinar, let's have a look at the chat or the Q&A to see if there are any burning questions.
There is a question about cholangiocarcinoma, suggests that we don't have to screen. I think the general consensus is, if you have a patient who on MRCP has a dominant or a hilar stricture, of course you should proceed to ERCP with kind of tissue diagnosis to kind of confirm. So you can suspect it, but screening, apart from doing, I think our general consensus is now to do more regular MRCPs in the patients with kind of significant sclerosing cholangitis. But apart from doing an ERCP and tissue diagnosis, that's the way to kind of diagnose it. So we wouldn't do that regular screening. Dominant bile duct strictures can be treated with ERCP. Yeah, some of these patients get stents and can get re-stented. Sorry, let me just see. If a patient is SMA and ANA positive, has highly elevated IgG levels but normal transaminase levels, and the histology did not indicate autoimmune hepatitis, is immunomodulatory therapy necessary? Should a repeat biopsy be performed? Patrick, do you want to comment on that one?
I would say that if a patient has no elevated transaminases, we are not going to treat the antibodies. I think that this is a clear example of a case where we are not completely certain that autoimmune hepatitis is part of it. And I would refrain from steroids or antimetabolites in these patients, unless they show more elevated transaminases. I would wait and see in that case.
The other thing that is sometimes challenging for hepatology side of things is that the patient might already be on treatment for IBD, which kind of potentially partially, and the other way around as well, autoimmune hepatitis already treated could probably partially mask IBD or the autoimmune disease, vice versa.
Yeah.
Do you have a preference about IBD activation before referral liver transplant or of the IBD PSC patients? I don't know what they mean with IBD activation. And then
maybe the thing is that
reassess.
once you refer a patient for screening for liver transplantation and the disease, the IBD is still active, would you try to induce remission in these patients before moving on to liver transplantation? That's the way I interpret this question. What would you do? What would be your advice, Marianne?
Well, we would differ. It depends a bit what their treatment has been for their IBD to date. We haven't had any problems with considering patients for transplantation that were on active treatment for their IBD. But of course, it's a concern if their disease is very active, and it depends how severe your liver disease is, I think, at the time.
And what about recurrence of PSC in the transplanted organ? The risk is probably higher when the bowel inflammation is still active.
Yeah, and I think in some of these cases, we do have kind of considered colectomy, depending on what the trajectory was of their IBD treatment before their liver decompensated. But again, the literature is kind of not in agreement with combining both. So another question, maybe Richard, should it be a monitoring interval of calprotectin in a patient with PSC?
So yearly, I think, is what we said in the paper. So, and the threshold is 150. So less than 150, okay. Over 150, do your scope at that point.
Would you do an MRCP if you already see bile duct dilatation, or do you use it for probable intervention? Patrick, you want to say?
I would say that MRCP is the imaging modality of choice, and it is more reliable than an ultrasound. But some ultrasonographers are very good in making a proper diagnosis. So I would say go for MRCP. Once you see that on an ultrasound, there are dilatations and strictures.
How often do you repeat MRCP during follow-up? So we now do it every 2 to 3 years, or if there's any changes on the ultrasound scan, but practices might differ.
Yeah, so the position paper says that you should not screen for cholangiocarcinoma. If that is the reason to perform an MRCP, then you should not do that. At least that's what we recommend. But there are other reasons to perform an MRCP. When the patient becomes more cholestatic, there is a clear reason to go for an MRCP. Are there any other burning questions, Marianne?
Immune suppression should be different in transplant to after, I probably mean after transplant to prevent recurrence. It's a tricky one. If there is autoimmune features, we would probably keep the patients on low dose prednisolone after transplant in association with the other. But again, that practice might be. So Benno is very keen to keep on asking the question about vancomycin. So I'll let Richard finish on a positive note with vancomycin.
So I would say yes, vancomycin does have a role in treatment. There is a couple of aspects to this question. So one is, will it help the PSC? Well, it helps the blood test related to the PSC, but there's no data to show it changes the long-term prognosis yet. It certainly does, in our experience, help with the intestinal inflammation as well, though. So we have treated a number of patients with PSC-IBD and seen their calprotectin symptoms get better, but I think interestingly also patients without PSC and just plain old IBD, particularly colitis, get better as well. So this is one of the important questions we would love to answer with a bigger collaborative group, and a great way to end is to say we'll answer that question together conclusively over the next few years with you and other people's help.
Thank you, Richard. Thank you, Marianne. With this, I would like to end this webinar. I would like to thank everybody for their attention, and I would also recommend to download the position paper next month, and probably we will have some discussion after you have read that as well. I hope you will enjoy the evening. Thank you very much, and bye-bye.
Bye-bye.
Bye.